So we have Laiq Raja in El
Good
Paso.
morning.
Good. Can we
Good
have
morning,
Laiq's?
Dr. Walker.
Yes, Laiq. So we're joined by a lot of great people up here. Nasanya Nar is here on the panel. We have a whole group. Anita Dua, Eric, Dr. Sia. We're going across just a great panel of guys up here. Tell us what you're going to be doing. And I didn't mean to leave anybody out. I'm just unfortunately trying to stay on time, which is what we've been asked to do. But can you show us? There we go. Now we can see you, Laiq. Tell us what your case is.
Very much for letting me do this case. We have this gentleman. Let's put the H&P on the screen. I know this gentleman for quite some time. He's 80-year-old gentleman who has a history of hypertension, hyperlipidemia, coronary artery disease, had a coronary bypass surgery done. And previously, he had some interventions done to his iliacs. He saw me a few months ago because of claudication. We did some ultrasound, and he had occluded SFA. So he underwent an exercise program, medical therapy, but he continues to have significant symptoms. So I decided to do an angiogram. So today he's here, and I have done some work already, and I will go ahead and show you some angio. If you have any questions, please let me know.
Sure. Okay.
So the ultrasound has shown that he had a distal SFA occlusions. So usually in that case, I usually go an anti-grade access so that my tools and my devices. He had quite a calcification, calcified vessels, but I was able to get through, and this is my diagnostic angios. He has a very nice proximal and mid SFA coming down here. You can see that it kind of occludes quite a bit of collaterals. And continue going down here, you can see there is a reconstitution of the mid portion of the popliteal artery. And it seems like he has a 3-vessel runoff all the way down, but very slow flow because of occluded SFA. Any comments?
Yeah, obviously, very, very dense calcium distally too. How long was that occlusion as you looked at it here, just to give us an idea about how many centimeters is the total occlusion?
Here, I think I have some more images here. So the occlusion, so this is, I'm putting a 645 sheath in it to give me a better support to it.
Okay.
And then here you can see that, so this is around about 15 centimeter.
Okay.
So it reconstitutes a little bit distally. So I broke the proximal cap by, this is a Navicross. In the beginning, I had some difficulty, but then I was having significant difficulty right this area.
Is this an 035 system?
The angulation of my cap. Excuse me?
Is this an 035 system, and what wire are you using?
Yes, it's a Navicross.
He's actually leading with the catheter here.
Sorry, I couldn't hear you. Yeah, I usually lead with catheter and usually use wire when I'm close to the distal cap. In my experience, if you have a good, this is a Navicross, which is my CTO device actually. It does a very good job of trying to stay in the lumen or breaking the cap. The issue with the caps is that the proximal cap most of the time is very hard if the CTO is for a long time. And breaking with the wire gets harder, and then if you try to push, the wire sort of buckles down and becomes subintimal. So usually I break the cap and try to go with the catheter Navi, which has an angle. You can direct it as much as you want and continue going. So as long as it continues to go, so right here, you can see these extensive collaterals, and I was having significant difficulty. So I brought CTO wire, Halbert 014. I usually start with 014 and then see how it goes. So here you can see, let me see the next one. So this is my wire, and even the wire was having significant difficulty, but then I was able to get through to this. And that's the distal cap. Usually that's the one, sometimes could be difficult, but actually I went through to this. And you can see it looks intraluminal.
Yeah. So Halbert,
And then I pushed my navi, and this area looks harder. I went through to that, and then just to confirm, I did a angio through the navi.
great job.
Looks like I'm intraluminal.
So Halbert is a high penetrance wire
So
made by
that's-
Asahi. And that was a great job of crossing, Laiq.
Thank you. So Asahi wire, Halbert, that's my to-go wire. This is how usually I start. I start with the catheter first, and then at least go half the way to the CTO, and then use the wire. Now, if the wire is having difficulty, and I think becoming subintimal, then I don't waste too much time and just go retrogradely and go retrograde. Most of the time, going antigrade and retrograde helps to get through to the CTO. My goal has always been to stay intraluminal. I think it's less trauma to the vessel, and usually at the end of the procedure, outcomes they look better. Try not to use stents unless it's a provisional stenting. So that's my usual way of treating.
So
Please, any comments, let me know.
yeah, so your plan now is you're going to stick pedal at this point because you think that you're somewhat subintimal right here. Is that correct?
No,
The lumen.
no.
Oh, okay. I misunderstood. I thought you were saying the wire was not passing now, and that you were going to gain distal. Forgive me.
Here's the-
Up it is up, coming down.
It looks nice. I mean, I'm seeing what.
So this is the catheter after crossing.
Okay.
So I hope you can see my angios.
We can.
Yep.
And did the wire pass
Okay.
at this point?
Yes, the wire has passed, and
Okay.
I pulled the wire out, and I'm injecting through the catheter to confirm the intraluminal positioning. And I'm also a very big advocate of distal protection because embolization does occur and more than we think.
Mm-hmm.
So next step was to deliver my spider filter, a 7.0 right here, the trifurcation vessels. Here you can see that. And next step, now I'm in the process of doing intravascular ultrasound. I usually do an IVUS. I'm sure all of you guys know. It's very helpful. It shows you the intraluminal or subintimal positioning. It confirms how did you cross the lesion, what's the morphology of the plaque, how much calcification. That helps you to pick your tools. Also the vessel diameter to see what kind of balloons you want to use.
Okay.
So here you see my sheet here. My IVUS is here, and we are going to go through this and see how it looks. So here you can, okay. So here you can see the vessel, some moderate calcium. Looks like I'm intraluminal, mostly a soft kind of plaque. Here you can see some more calcification coming down. And here, so there are areas, so here you look like a almost 360 calcification. So it's a mixed morphology. coming all the way down, and this is the distal area. So we can measure it. Any comments?
Comments
what would
from
be
the panel?
next,
I think there are portions where you've traversed subintimally. I think you go in and out.
Michael, how often do we not go in and out in
Yeah.
this kind of a lesion? I think,
Oh, I think that's one of the challenges, and I think Dr. Raja made a great point. You know, if he was struggling to come from above, you know, retrograde access, the morphologies of those caps, I think would have made. I mean, you can't guarantee you're going to be intraluminal when you cross from below, but I think it may have resulted in a different outcome. But I think for these types of lesions, I've got a pretty low threshold to use. To think about stenting, especially if they've previously been intervened on.
yeah, and you know, we look at this, and if we look just simply at the fluoro, we would all say, boy, that's a lot of calcium, right? And historically, that means let's pull X device or another device. Yet this is mostly medial calcium, as we're looking here. This is not intraluminal calcium. And I think this speaks really to volumes of the use of ultrasound. It drives me crazy that people say they don't use ultrasound because it gives them too much data. That's like telling a woman she's too pretty. That's just stupid, okay? And I think this is silly. We should be smart enough to use that data when we see it. So, Laiq, you're a dog. You've just captured this bus, and now you got to do something with it. You know, that's where the dogs have problems when they actually catch that bus that they've been chasing. So, tell us how you're going to treat this patient.
And also, I also strongly believe in plaque modification and debulking before I do any sort of a ballooning or, as I said before, a provisional stenting. In my experience, stents, yes, they have a good place, but they also have a lot of problems related to that. Stent fractures, thrombosis, restenosis, all of those things. So I try to avoid putting any sort of metal inside the artery unless it's really, really needed. So to do that, one of the main reasons you end up stenting is because probably the vessel prep was not good enough. And of course, if I go and balloon right now, it's going to just fracture or dissect the entire artery. And then you have no other choice than to put some sort of a scaffold. But if you do a good debulking and then hopefully low pressure balloon angioplasty, and in this case probably we use a drug-coated balloon to deliver a drug, and even there is mild dissections, but good flow, I will just leave it alone unless the dissections are significant and the outcome doesn't look good. So what sort of a debulking in this case? I think, as Craig, you mentioned that most of the calcium doesn't look like in the luminal part. There are certain areas, yes, you can see that, but most of the time it's a soft flag and it's a medial calcification. So when I like to choose my device, for these kind of a thing where it's a soft plaquing, I think a couple of atherectomy devices I like to use. One is a laser atherectomy and the other one is a HOG, turbo HOG. Both of them are very good, especially the laser one with turbo power toward does a really good debulking, and HOG obviously yes. So only thing I'm kind of a little concerned is that there are certain areas there's a lot of calcium and HOG may not get through. So I'm probably gonna do a little bit, give me a 3.0, maybe 3.080 balloon. I'm gonna do a little bit of predilatation so that I don't hurt the artery when I'm doing the HOG to remove the plaque. And after that, we'll take some more images and I think we'll decide. Now, if you guys want to go and do a couple of presentations, that'll be a good time, and I will come back and show you after my atherectomy, how does it look, and then we can talk more.
Okay, hold on just one second, because Anahita has a question.
So a quick
Yes.
question. What's your thought on shockwave
Yeah.
in a position like this? Not everyone has everything, unfortunately. Certainly where I am, we're now going to have the laser, but even like the bioabsorbable stents have been really difficult to get. And we have only certain types of stents. For example, we don't have Sapera, but we have Alluvia, like things of that nature. And so what's your view? Because we do have shockwave. Most people have that. Would you consider that here?
I agree. Shockwave could be a good choice. Though unfortunately, we are in an office-based lab, and we have limitation what we can use.
Yeah, I don't,
So, as like you said, you have certain things available and some not. So that's one of the reasons is, but even shockwave, it's a great technology. And usually I use them if there's a severe calcium 360, and you can just see them really. It's very effective. It's a circumferential calcification. It works very well. But if it's like an eccentric, one-sided, we see like a popcorn sort of a calcium, it's not very effective in my experience. I don't know. I would like you guys to tell me your experiences.
Sure.
But yes, intravascular lithotripsy has changed our practice.
Cool. Yeah, we'll certainly talk about. It's interesting you mentioned you're at Mass General, and you're talking about the tools you don't have. In my ASC, I actually have Shockwave. I do have Supera. I do have Alluvia. I do have Zilver PTX. It's part of why I built
Gotta
an
move.
ASC. But we'll have a conversation on that later today, and so I'm very curious to hear how that conversation goes. Because, sometimes hospitals don't give us all the tools that are contemporary, and as specialists, when we have an ASC, we can do that. But thank you. Hi, Laiq, we see you back.
I'd like to show what I did. So after doing an intravascular ultrasound, I decided to predilate with a very small balloon 3.0. And after that, we did, here you can see that. So this is a directional atherectomy. I like it because you can direct your cutter, the area where you want to cut more, and then you can change the directions so that you can go 2 quadrants, 4 quadrants. And the whole objective is that to try to remove as much as plaque possible with the hoping that eventually you do not have to have a high inflation in the ballooning, particularly this sort of a calcified artery. So it takes a little longer, it takes a while because you have to do a lot of cutting, and in this case, I had to take it out a couple of times because the nose cone was full. And once I'm done all the way down to the lesion, then I take an image. Here you can see all the way to down, there's a lesion I think I was not able to get to, but we already have a lumen. So I continue to have a little more atherectomy, debulking, and I had to push my filter a little bit down because the nose cone was not letting me get there. And after that, again, I started coming down, going all the way to the distal end to cut that area where there was another tight lesion. You have to be very slow. You have to give your device a time, like any device, to work. If you go fast, then it's you're kind of doddering, not really removing a plaque. So in this case, I did all quadrants of the vessel. Once doing that, then you can see this. This is just atherectomy without anything else. I think looks good. You can see the collaterals are much less. There's a TIMI-3 flow now. So at this point, I decided to deliver a drug. So this is Impact, 50 to 50. We went to 6 atmospheres in this calcific artery and actually kind of expanded fairly well all the way. So we leave it for 3 minutes. So after 3 minutes, balloon was removed, and this is an image. And this is the tibial, and we go usually all the way down to the foot to make sure, even with the distal protection, there is no embolization. And then obviously we have the image prior to doing, so we can compare everything looks good. So I think I will stop here unless there is any comments, anything else anybody wants to add to it.
Yeah, I think this is beautiful. Let me ask you something. You already had the IVUS out. Could you give us a quick run of IVUS just to see what this looks like after? You know, I like IVUS pre-case. I think it tells us information. I like IVUS post-case too. You know, we have found often that things look one way angiographically and another way by IVUS after. And again, as I've said before, I've heard people say, well, what do we really get at that point? Because it's information, it's going to get us into trouble. I'm not sure you can have too much information on the patient. I think the more points of knowledge that we have on a given case, the better the outcome. Any comments from the panel on that?
I think there's a learning.
Dr. Walker, are you thinking that you would find information that would now force you to put a stent in? Because these lesions usually look very nice on angiography, but when I do IVUS, they look very ugly.
Well, if I find information that makes me think I should put a stent, then I would. If I find information I don't, then I would not. No, I'm not suggesting that at all. I just think I find the argument that I don't want to see it because I might treat it. I find that to be a bad argument, personally. I mean, I don't understand the logic of that.
I totally agree with that. And I also wanted to comment on one thing while you were talking about the wires. Can you come and talk to some of those materials manager? Because for them, 014 is 014.
Yeah.
The minute you ask another wire, like, oh, we have it on the inventory. Yeah, I think that education is required.
Yeah, that's the advantage of having an ASC. Because you choose what you find necessary. No, I must
Absolutely.
say, I didn't build an ASC to make monies. I built it because I felt hospitals were ripping off my patients and because they weren't giving me the equipment or the personnel I needed.
I agree with that,
Yeah,
Dr. Walker.
and that's a very, and so I still work in a hospital, of course, and I manage the hospital contracts, but we need equipment. And unfortunately, we're letting the MBAs tell us what equipment we need to use, and I think that's absolutely crazy because you can't do the best job if you have half-assed equipment or techs to work with.
Gosh, we were in China one time doing cases, Craig and I, and they said, what kind of wire do you want? You get an 014, an 018, or an 035.
And that's all they had.
Those are your three choices.
And
Which
they
one
gave
do
me
you want?
and they gave me an occlusion that was
Yeah.
50 centimeters long to do live.
No, but
Months
that,
later.
Yeah.
We did it. We got it, by the way.
yeah, that is very common.
I think that to your point, though, is that if you're going to do IVUS, and I agree with Craig, you have to have a plan of what you're going to do with that information, and just simply do it to do it.
That looks
But if
nasty.
you look at it and you say you still need to put a stent in, I think then you're obligated to put a stent in. But these never look as good as you think they're going to look when you do IVUS.
Well,
You have to have
know,
a plan.
Sometimes it's as simple as I choose to slightly upsize a balloon.
Correct.
Yeah.
Okay, and so, I'm not suggesting that means a stent. I'm just suggesting a lot of restenosis, that we call restenosis, I'm afraid, was suboptimally treated stenosis in the first place.
Yeah.
And I think we hurt our patency when we don't.
I agree.
Yeah, I think we typically vastly undersize these devices.
So Laiq, what are you seeing here, bro? I was looking over to the other side.
That is very tight areas that I saw.
Yeah.
Thoughts about post-procedure IVUS. I don't do it. Because I know actually angiographically looks good.
Same reason.
I just leave it alone because I know it's gonna so ugly, and then it makes me do something. And so the reason I do IOS is initially is to make sure I'm intraluminal.
That's very-
Number two, see what's the vessel size, what's the morphology, what's the calcification. So those are the things helps me to pick the tools where I'm gonna use, atherectomy or ballooning and all that. And then after that, I do a ballooning, the balloon is expanded fairly well, there's not much waste. And then angiographically, it's a TIMI 3 good flow. There are certain areas, certain dissections. I don't want to do it because I'm not going to do anything, whatever the IVUS shows.
Yeah.
It's just me. I mean,
Yeah.
it's just me because, of course, when you go and take a look at the IVUS, there are certain areas. There is no way you can remove all the plaque, even doing all sorts of atherectomies and ballooning. So if in this case, now you guys looking at IVUS, what you guys would do? Tell me.
I would balloon this with a 6 millimeter focal force balloon at low pressures at this point. If you're asking what would I do based on what I'm seeing, I would use a focal force balloon. I would stay low pressure. I would go up to 6 millimeters. I think if we measure lamina, I think that's the size of this vessel. I would stay low pressure, and I think you might get a bit additional gain. I applaud everything you did. This is good. This might stay open. Maybe I'm totally wrong on this, but I think we still have some stenoses in here that if you saw up front, you might still treat. Yeah, there's a question. Oh, yeah, Louis Leon has a question.
Raj, I also have a question. Is
decision has to also involve the indication of the case, meaning that if you have quite a bit of tissue loss, you really want to get a result closer to perfection. But
The 80-year-old.
Okay, let me have a 6-150 balloon.
Yeah.
Okay, I will.
Yeah, Luis Leon was saying he thinks the indication of the thing, and this was not for tissue loss, this was for claudication. That's true. I guess, frankly, I'm one of those guys that thinks I want to shoot for perfection at all times if I can. And that may be an enemy of good, for sure. I think the risk of using a low-pressure focal force balloon here to follow this is minimal. And I think if you get a better result, you get a better result. Again, one of the things that we face, one of the great criticisms of intervention from day one has been that they restenose a lot.
Yeah.
We can't ignore that. We can't ignore that. And that's one of the reasons people say you shouldn't do it for claudicants. If we had no restenosis, that question would be asked a lot less.
So here's the paradox, Craig. I'm gonna come back to you, Nelson. Here's the paradox. You put in a stent, you're being accused of being greedy because you just put in a stent for no reason. Or you don't do it and they come back in 6 months and then you put in a stent, you're gonna be accused of being greedy because you didn't do it, because you did it. So you can't win either way. But I agree with you, I would get burnt, Nelson.
So, Craig, were you not concerned that you already delivered an ECP and then you're going to mess it up again? So
I don't think you,
mitigate
no.
I think the
I
drug
don't
is
think-
on the wall of the artery. I don't think it's gonna.
The drug is there.
Yeah.
Well, Nelson's not sure whether the drug stays there or not, and that may be right. I don't think we know. I don't think we know that. In Europe, they've used it a lot. In Europe, where they've reported a lot of data after they've post-dilated, with this, their patency rates always came back better than ours if you look at them. But I don't think we know that. I'm asking this as, just to create discussion. Do we accept half-assed versus perfect? And I think this is not half-assed, obviously.
Right.
This is much better.
Right.
I'm not suggesting this is half-assed. This is a very good,
That's what I was gonna say.
very good result on a very tough procedure. No, I think this is for purpose of discussion. At what point do we think good is good? And do we have to recalibrate ourselves? Because what we've done has still resulted in high rates of restenosis.
So I have a question. This looks like a redo procedure. Dr. Raja said that the patient had a previous occlusion. Was it in the same location? Because if it's the same location, then you probably want to be more aggressive.
Those are iliac. This is first time.
First time. Okay.
Yeah.
Sick-
Well, I'll do a low pressure ballooning. Go ahead.
Is this
But,
focal force? Is this focal force, or is this, what kind of balloon? Go super slow, guys. Is this focal force?
Regular balloon.
Yeah, so obviously,
No,
when we
which one
look,
is-
yeah, I'm
Which
sorry.
focal force which balloon are you? Chocolate or?
Well, chocolate is one, ultra score would be one, stellar, what's?
Angiscore.
Angisculpt is one. There's a new one out called
Serenator.
Aperta that came from Nipro, and Serenator. Those are the ones that I know of right now. There may be more. But certainly, you know, going all the way back, some of the balloon experts, Ron Solar in particular, talked about what were those factors that caused dissection. And number one biggest was strain. Strain is how fast, how rapidly something goes up. So if you think of about a ball of Play-Doh, if you take it and you pull it apart very, very slowly. By the way, Play-Doh was invented in Opelousas, Louisiana, just a little small point, but by one of my patients. Okay, but anyway, you pull it apart very, very, very slowly, it stretches. But if you take it and you rip it apart quickly, what happens? It comes apart. That's what creates dissection. And from a physics perspective, that's what strain is. The rate of inflation is strain. And going up really slow helps. Now, that's what focal force does. Focal force, by having areas that are sharpened at the tip, be it the razor blades with the Buroth balloon, be it the wedges on a Perto, be it the blades on Serenator, be it any of these things, they're creating an area of high force. And so you're concentrating force, allowing your balloon to go up at lesser pressure and to be a more controlled inflation. And that seems to result in less dissections. Okay. Looks much the same, doesn't it? Okay. Can we take one quick IVUS and see if we've made any difference? Who knows? You might have convinced me to not waste all my time with ultrasound. It certainly takes a little extra time, but we'll see. But I think theoretically at meetings like this, we have to challenge ourselves to how do we improve a field? Do we just accept where we are and say it can't get better? Or do we say, maybe we could think a little bit more? 100% that's true. Yeah. 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 But that may be right. No, I'm not suggesting I have the absolute answer. I'm suggesting, though, what we've been doing has still resulted in way too high a restenosis rate. And until we look at it and we say, okay, we haven't solved that puzzle, and we try all of these things, then if it fails, and we'll report that. But
technique can help with this. We've come a long way.
Yeah.
From our day of
Utilizing drug-coated balloon has made a difference.
Oh, for sure, Laiq. And look,
You know that.
yeah.
Yeah.
Just curious to see what this looks like.
We did that. We did atherectomy. I think I don't shoot for 100% because it's never going to happen.
That's true too.
I clinically take a look and see if clinically looks good flow, no major flow-limiting dissections, and then, stop there, and then we see these patients for a long, long time. Okay, just start recording again.
Okay.
See, so.
No, I don't think that looks the same.
No, I don't. I think it looks a little
I think
better.
cross-sectional area, you're substantially bigger here.
Yeah. I think,
I guarantee you have more cross-sectional area now.
Yeah.
Not even close.
I think from a claudication standpoint.
So I was right.
No.
No, I think, and look, this is meant to be some levity and this is meant to be fun, but I think when we look and we are criticized with how high a restenosis rate we have, I think we have to keep saying, what can we do to make that less? He's used a drug-coated balloon. He's used atherectomy. Atherectomy is absolutely right now under fire. People are saying you're a criminal if you use atherectomy. It's an FDA-approved product, and certainly with balloon alone, you would have never gotten this kind of a result. I think, Laiq, that looks much better, and I would absolutely leave that here. I now am looking at your lumen. I see no area there that I think represents more than a 50% luminal encroachment. I saw some before that did. What do you think?
Before I leave, I'd like to introduce my colleagues here.
And you don't want me on a panel ever again, right? Okay. What you got? Okay.
Experience about 15 years. He's one of the best tech. We stole him from the hospital. Felipe is in the back. He's Our circulating nurse is another one of the best. And then we have some colleagues from industry, from Medtronic, Jacob and Matthew from Asahi here. They're helping us today. So I will be back around 10:30. We have another case, infrapopliteal CTO. I think it looks pretty challenging, but we'll see how it goes.
Laiq, beautiful job. Congrats. Really beautiful.